Talk about respiratory mechanics, the mechanics of breathing, moving air in and out of the lungs. There's a lot of material and I may not get through it all, so if I do not, then the next time I come in, we will continue with whatever I don't get to. So our objectives this morning are to describe the actions of the respiratory muscles, to describe the normal pressure-volume relationships of the lungs, chest wall, and respiratory system, explain the importance of surfactant in the lungs, discuss the effects of the pleural pressure gradient, compare laminar and turbulent flow, describe the effects of the equal pressure point, and use time constants to explain distribution to gas flow. And again, that's a lot of material, and if we don't get through it all this morning, we'll just pick up the next time that I come back. I will try to share with you a few clinical consequences of some of this physiology as we go through it, but this morning we'll be talking primarily about normal respiratory physiology. And then I'll follow up on the next presentation by talking about some of the implications to patients, particularly those who are mechanically ventilated. So let's begin then with a discussion of the respiratory muscles. And as we think about respiratory muscles, we can think about the inspiratory muscles and the expiratory muscles. The primary muscle of breathing, as you know, is the diaphragm, and that accounts for 70% or more of the muscle effort that is required for inhalation. The external intercostals are also important, and they provide the other 30 or 20 or 30% of effort during normal inspiration. And then there are a number of accessory muscles that are only invoked during stress. During exhalation, exhalation is normally passive, so we use our respiratory muscles to inflate the lungs, and then the elastic recoil pressure of the lungs is what drives the gas back out of the lungs. So normally exhalation is passive. If someone is actively exhaling, that is not normal. There are a number of accessory expiratory muscles that are invoked during stress. So that could be stress during disease, or that could be stress during exercise, for example. So during maximum exercise, like when you run to the North Station this afternoon, you may be invoking all of these muscles. This illustrates some of the actions of primarily the diaphragm. So it illustrates that the diaphragm contracts downward. That produces the negative pressure that draws breath into the lungs. The downward expansion of the diaphragm also pushes out on the lateral rib motion. So when we breathe in, the action of the diaphragm is that the diaphragm moves downward to increase the volume of the thorax. The diaphragm also moves the lateral ribs outward to increase the volume of the thorax, to decrease the pressure in the thorax, draw breath into the lungs. As the diaphragm contracts downward, it also increases the intra-abdominal pressure, and it pushes the abdomen outward. So with normal breathing, the chest should go out. That's the action of the chest wall muscles and the diaphragm. The abdomen should go outward, and in fact, if as one breathes, the chest goes outward and the abdomen goes inward, that is abnormal, and we'll discuss the significance of that a bit more in a few minutes. So normally during inspiration, the diaphragm goes down, intra-abdominal pressure goes up, pushes out on the abdomen. Abnormal if that does not occur. Also, as is illustrated here, that when the diaphragm contracts and when the chest wall muscles contract, the external intercostals contract, that lifts up on the ribs. So the contraction of the chest wall muscles lifts up on the ribs, also lifts up on the sternum. So we have the sternum that moves outward, and we have the ribs that get lifted up and assist with the outward motion of the thorax. So the net result of this then is that during inspiration, the intrathoracic pressure becomes more negative as the intrathoracic volume increases. That produces the negative pressure to draw breath into the lungs, and during exhalation should be passive, does not require muscles to push the gas back out of the lungs except during stress. So illustrated here is the innervation of respiratory muscles. So this becomes important when we think about patients with spinal injury, for example. So the diaphragm is innervated by the phrenic nerve that arises from C3, 4, and 5, relatively high up in the neck. And in fact, if there is injury to the spine above the level of C3, that is incompatible with breathing without respiratory support. So if one has a very high cervical spine injury, like a C1, C2 injury, that means that that person will need respiratory support, likely for the rest of their lives. The accessory muscles arise from C4 and below. So if a patient has an injury to the lower cervical spine or to the thoracic spine, they may be able to breathe on their own without respiratory assistance because the phrenic nerve is intact. The diaphragm can be used. However, they cannot use the accessory muscles of inspiration or exhalation. So that an individual with, say, a T1, T2, T3 injury will be able to use their diaphragm, but they will not be able to take a deep breath to full total lung capacity because they do not have use of their accessory muscles, and they will not be able to cough effectively because they cannot use their expiratory muscles, which are important for coughing. So what are then some of the clinical consequences of this? So what about a patient with diaphragm weakness, like a patient with ALS? So a patient with motor neuron disease, like ALS, who has diaphragm weakness, they will often complain of orthopnea, meaning that it's difficult for them to breathe when they are lying flat. So they can breathe more easily when they are sitting up. So in a patient with orthopnea, due to diaphragm weakness, the vital capacity actually might be lower in a supine position than in an upright position. And when I used to work in the ALS clinic here, we would see patients whose vital capacity may be 60 or 70% of predicted when they are upright. But when they are supine, their vital capacity may drop to 40 to 50% of predicted. A significant reduction in vital capacity in the supine position. And the reason for that is if the diaphragm is weak and you are in a supine position, the abdominal contents push up on the diaphragm and it makes it more difficult to take a deep breath. So that's kind of an important thing to keep in mind, partly because in patients with ALS and progressive neuromuscular disease, they qualify for non-invasive ventilation as far as payment from insurance companies when their vital capacity drops to less than 50% of predicted. So if they tell you, you measure their vital capacity and it's 60% of predicted or 70% of predicted, but they tell you that they're short of breath, particularly when they lay down, it's worth putting them flat and measuring their vital capacity, because if there's a significant reduction in vital capacity in the supine position, that is consistent with diaphragm weakness. Now, the opposite of orthopnea is platypnea. So with platypnea, the patient is more comfortable breathing when they are supine than when they're upright. And this can occur with spinal cord injury below the level of the phrenic nerve. So in a patient who has a thoracic spinal cord injury, for example, and is quadriplegic, that patient will be able to breathe because the injury is below the level of the phrenic nerve, However, they won't be able to use their accessory muscles. So when they are upright, the abdominal contents fall downward. That pulls down on the diaphragm, and the diaphragm is less effective. So there are more shorter breaths sitting up. However, if they are placed flat, the abdominal contents push up on the diaphragm and puts the diaphragm into a position where the patient is able to take a deeper breath. So in patients with quadriplegic patients with thoracic spinal injury who can use their diaphragm but cannot use their accessory muscles, often the vital capacity is lower in an upright position than it is in a supine position, and those patients will prefer, for their breathing, to be flat rather than sitting upright. And in fact, if you try to sit them upright, they will get more short of breath. The opposite of what happens with diaphragm weakness. And one of the simple therapies that is used in such patients is an abdominal binder when they're sitting up, like when they're gotten out of bed into a chair and they're sitting up, to place an abdominal binder. That pushes in on the abdominal contents, pushes up the diaphragm, has the same effect as a supine position. It's also important to appreciate that the accessory muscles are paralyzed during REM sleep. For you or me, not a big deal. So we go into REM sleep, our accessory muscles stop working, but our diaphragm still works. Our diaphragm's responsible for most of the inspiratory effort. So during REM sleep, we may not breathe quite as much, and our PCO2 may go up a few millimeters of mercury, but not really a big deal. However, in a patient with diaphragm paralysis, if they fall asleep, go into REM sleep, so a patient with diaphragm paralysis going into REM sleep loses the use of their accessory muscles, their diaphragm doesn't work very well to begin with, so that then they become hypercarbic during sleep. And this is a big issue in patients such as those with ALS, for example, where they become hypercarbic when they're in REM sleep, and the reason for that is that their diaphragm doesn't work very well. They're dependent on their accessory muscles. The accessory muscles do not work during REM sleep. Hence, that's part of the reason why patients with neuromuscular disease, such as patients with ALS, are initially placed on nocturnal, non-invasive ventilation. So a classic way of measuring the strength of the diaphragm is by measuring transdiaphragmatic pressure. And the way this works is we place a balloon tip catheter in the esophagus to assess the pressure above the diaphragm, thoracic pressure, intrathoracic pressure, and another balloon tip catheter below the diaphragm in the stomach to measure intra-abdominal pressure as gastric pressure. And the transdiaphragmatic pressure is the difference between the pressure that is measured here in the stomach, abdominal pressure, and the pressure measured here in the esophagus, intrathoracic pressure. So normally what happens is the diaphragm, when it contracts downward. The pressure in the thorax becomes more negative. The pressure in the abdomen becomes more positive. That's what pushes out the abdomen during inspiration. And the transdiaphragmatic pressure increases. This becomes more positive. This becomes more negative. Now, what happens in the patient with diaphragm paralysis? So in the patient with diaphragm paralysis, during inspiration, the pressure in the thorax becomes more negative because of the contraction of the accessory muscles. So the accessory muscles contract, and that causes the intrathoracic pressure to become more negative. But if the diaphragm is paralyzed, the diaphragm gets sucked upward as a result of that negative intrathoracic pressure, and that's what causes the abdomen to move inward, paradoxical breathing, in patients with diaphragm paralysis. So then what happens with diaphragm paralysis? The accessory muscles contract, the intrathoracic pressure becomes more negative. The diaphragm, because it's paralyzed, gets sucked upward. That causes the intra-abdominal pressure to become more negative. And then what we see clinically is abdominal paradox. So instead of the chest and the abdomen moving out during inspiration, the thorax goes out and the abdomen goes in. And this can be quantified, if you so choose, by placing a balloon-tip catheter in the esophagus and in the stomach and measuring those pressures. So just to show you that it's possible to do this, this was a patient who was up in the old Bigelow 9 RACU many years ago. We published this paper in 2005, so this patient was probably in the RACU maybe not too long after it opened. When did you start working up there?
2003.
Yeah, so you might have been there when we did this. So what I did was I took 2 esophageal balloon catheters, and one of them I placed into the esophagus to measure esophageal pressure, and the other one I pushed all the way down into the stomach to measure gastric pressure. And what you can see is that, so I see now that this is, this is correct. So what you can see is that in this patient, when the patient breathed in, so this is inspiratory flow, the esophageal pressure went down. That's what you would expect. So that represents intrapleural pressure. In this patient, however, the gastric pressure, the pressure down here in the stomach, also went down. So normally, this pressure should have gone up when this pressure went down. Make sense? And in fact, in this way, we diagnosed diaphragmatic paralysis in this patient. And in fact, the reason why it was impossible to wean her off of the ventilator was because of her diaphragm paralysis and multiple other issues that she had. So again, here we're looking at esophageal pressure. So when the patient breathes in, by the way, the patient's disconnected from the ventilator. So all this doesn't make any sense if the patient's connected from the ventilator. Connected to the ventilator. So the patient's disconnected from the ventilator. Patient breathes in, the intrathoracic pressure goes down, so the esophageal pressure goes down. The diaphragm is paralyzed, so the diaphragm gets sucked up by the accessory muscles, so the intra-abdominal pressure goes down rather than going up, which is illustrated here. Now, there are other ways to look at this that I think can be clinically useful sometimes. So another way of getting at the intra-abdominal pressure, other than putting a balloon into the stomach and measuring gastric pressure, is to measure bladder pressure. So bladder pressure is a reflection of the intra-abdominal pressure. And the way we usually think about the bladder pressure is we think about it as being a static measure. So we say the bladder pressure is 25 millimeters of mercury. But you can actually gather information from the bladder pressure by looking at how much it fluctuates, varies over the respiratory cycle. So we can use bladder pressure to get intra-abdominal pressure, and we can use respiratory variation in the CVP to get intrathoracic pressure. Because as you're breathing in and out and your intrathoracic pressure is going more and less negative, that affects the central venous pressure, the central circulation, so that with spontaneous breathing, the CVP goes down during inhalation and it goes up during exhalation. So then, in a patient with diaphragm paralysis, during inspiration, we would expect that the CVP would go down. And what would you expect would happen to the bladder pressure with diaphragm paralysis? Go down. Because with diaphragm paralysis, the accessory muscles stuck up on the diaphragm, the intra-abdominal pressure goes down, the thorax moves inward, so we see paradoxical breathing, and the bladder pressure should go down rather than up. So here, this is when digital cameras weren't what they are today. This is actually a patient over in the SICU. This is probably 15 years ago. I remember I did not have a camera on my cell phone at the time. We had to go find a digital camera so that we could take a picture of the monitor. And what we're looking at here is this waveform is bladder pressure. So we're not looking at a single bladder pressure, we're looking at bladder pressure over time. Here is the CVP, and here is respirations taken off of the ECG monitor with changes in electrical impedance. So this is breathing in, breathing out, breathing in, breathing out. This is a patient who had failed multiple spontaneous breathing trials and extubations. And it was suggested that as a result of the surgery that she had, that there might have been phrenic nerve injury and diaphragm paralysis. So, does she have diaphragm paralysis? Yep, because you can see that when she breathes in, again, disconnect her from the ventilator, and she's saying, I can't breathe very well. Oxygen saturation is down to 89%. So shortly after we took the picture, we put her back on the ventilator. So you can see, breathes in, CVP goes down. What is the CVP to go down? The intrathoracic pressure goes down. The bladder pressure also goes down. And what it should have done is to go up. So diaphragm paralysis. I actually think this happens a lot more than we might appreciate. Carolyn probably remembers from the rescue. This would be sort of part of our usual drill. In the MICU as well, for you guys that work in the MICU. So you've heard me go through this at the bedside probably more than once already. So here is a video. You might have been there for this one too. I don't know. So here's a patient who has diaphragm paralysis. And we were so excited about it that the next day I brought my video camera from home so we could do a video of this. This is Bob Brown's favorite video, so if I haven't shown it to you before, perhaps he has. So in this patient, as I run the video, what I want you to see are these things. So first of all, the patient, when disconnected from the ventilator, actually I think the patient's connected on 0/0, but with the patient getting no support from the ventilator, notice the paradox. So you'll be able to see that the chest goes out, the abdomen goes in. So you see paradox. Then what I'm going to show you in the video is the Foley catheter with some air in the Foley catheter. So we put a little bit of air, a little bubble of air, a couple bubbles, actually a fair amount of air into the Foley catheter. And you're going to see that the urine is going back and forth in the Foley catheter. And then we're going to see how the air moves in the Foley catheter as the patient breathes. So let's think about this now. So if the patient is using his diaphragm, when he breathes in, diaphragm goes down, abdominal pressure becomes more positive, bladder pressure becomes more positive. So what should be the direction of the urine in the Foley catheter? Towards the patient or away from the patient? Normally, away from the patient. The patient has diaphragm paralysis. What we should see is when the patient breathes in, chest goes out, abdomen goes in, and the bubble moves towards the patient. So let's watch the video. Okay, here we go. So here's so I think you can see the paradox. Everybody see the paradox? So chest is going out, abdomen's going in. So that's the first clue that this patient has diaphragm paralysis. And he's turning down the volume so that we can talk, although I wasn't recording any volume. So here's the Foley catheter. See the urine going back and forth. Up here we put an air bubble. Just shove a little air in through here. Okay, and now let's see what happens. So here the patient breathes. When the patient breathes in, you see the chest go out, the abdomen go in, and the air bubble goes towards the patient. So in, out, in, out. So you too then can diagnose diaphragm paralysis at the bedside just by looking at which direction the urine moves in the Foley catheter. So it's fun to be able to put in catheters and make some of these measurements and so forth, but really it can be done pretty simply. Here again, when the patient breathes in, chest goes out, abdomen goes in, urine moves towards the patient. Do we all agree? So this patient has diaphragm paralysis. Had failed multiple spontaneous breathing trials, is trached, and in fact, at this point, we begin discussing whether the patient's just going to be on long-term mechanical ventilation. Okay, we don't have, well, we can look at it again if you want. Now I have to figure out how to advance the slide. So a term that has been introduced just over the last, well, probably over the last 15 years or so, and is being thrown around a lot more in the literature, is ventilator-induced diaphragm dysfunction, or VID. So if you hear somebody talking about VID, that is ventilator-induced diaphragm dysfunction. And the idea here is that with controlled mechanical ventilation, like with heavy sedation or heavy sedation and paralysis, that can result in diaphragm weakness due to atrophy. So this is attenuated during patient-triggered modes of ventilation. So if the patient's triggering the ventilator, even with fairly high levels of pressure support, that may attenuate the degree of VID that will develop. VID may contribute to ventilator liberation failure, and that is receiving more and more attention in the literature. So to the extent possible, it's prudent to avoid prolonged use of paralysis in patients with respiratory failure. So for example, paralysis is recommended for severe ARDS, however, only for 48 hours, because prolonged paralysis can contribute to diaphragm dysfunction. But it's also important to appreciate that excessive effort can also result in diaphragm injury. So it's kind of important to get it right, because if the patient gets too much support, that can result in diaphragm dysfunction. If the patient gets too little support, that can also contribute to injury. And this is from a review published within the last year, illustrating some of these things, and I'm not going to go into detail on this slide, but it makes the point that with a high activity of the diaphragm, if the patient's diaphragm and respiratory muscles are working hard, that can contribute to diaphragm weakness. If the patient receives excessive onloading, prolonged paralysis, for example, that can also lead to diaphragm weakness. So then it's important to get it right. We don't want the patient to work too much or too little, both of which can result in injury. And this is receiving, as I said, a lot of interest in the literature these days, and a lot of discussions about how we can assess this, how we can prevent this, how we can treat this. So then how can we measure the strength of the respiratory muscles? Well, this can be done by measures that all of you have done many times, some of you maybe more times than I have. This is measuring the PI max and the PE max, or the MIP and the MEP, the maximum inspiratory and maximum expiratory pressures, to measure inspiratory muscle strength and expiratory muscle strength. One thing that is important, as I'm sure you know, is to measure the maximum inspiratory pressure at residual volume and the maximum expiratory pressure at total lung capacity. And the reason for that is shown on this slide. So the maximum force generated by the muscle is at 100% of the optimal resting length. And for the inspiratory muscles, that's at residual volume. For the expiratory muscles, that's at total lung capacity. If the patient has a decrease in maximum inspiratory pressure, the patient needs ventilation. So that's why we measure that. Patients with neuromuscular disease, for example, and with decreased maximum expiratory pressure needs some form of cough assist. So there may be some patients like those with spinal cord injury who might not need ventilation, depending upon the level of the injury, but they still might need cough assist because they cannot use their accessory muscles effectively to cough. So what are normal values? Well, various normals have been published many years ago. I think it's fair to say that most of us should be able to generate an inspiratory pressure of at least 90 to 100 centimeters of water. Maximum expiratory pressure is greater than maximum inspiratory pressure for males, young males should be able to generate about 200 centimeters of water, about twice what is the inspiratory pressure. These numbers, the maximum inspiratory and expiratory pressure, are actually more helpful if monitored over time. So in patients with rapidly progressive neuromuscular diseases like Guillain-Barré syndrome, maybe measuring it as often as every 4 to 6 hours. Patients with slowly progressive disease like ALS gets measured every 4 to 6 months. So then how does the maximum inspiratory pressure relate to changes in blood gases like PCO2? Well, as you can see on this slide, when the pressure generated is decreased to about 50% of normal, there's not very much change in PCO2. So we can have, or our patients can have, significant respiratory muscle weakness before they become hypercarbon. But notice that when the respiratory muscle strength drops to about 50% of predicted, further reductions in the respiratory muscle strength are associated with an increase of PCO2. So that then might be justification for why it is that patients with ALS get started on BiPAP when their vital capacity drops to 50%. Now, something that I wanted to mention, because it is being described increasingly in the literature as a way of assessing the diaphragm, is diaphragmatic ultrasound. So illustrated on this slide is the kind of thing that you might see from diaphragmatic ultrasound. There are, I don't know if anybody is doing this here. I know a couple of years ago, I don't think there was really anybody who was clinically doing diaphragmatic ultrasound. But this is being used increasingly to assess, particularly patients who fail spontaneous breathing trials, to see if diaphragm weakness may be the issue. So here we're looking at the diaphragm. This is the diaphragm. And if you look here with a strong effort, you can see that the diaphragm thickens during inspiration. So as the diaphragm contracts, it thickens. That makes sense. Just as when you contract the muscles in your arm, they thicken. And here you can see the diaphragm thickening during inspiration with strong effort. So this is called the diaphragm thickening fraction. So you can actually calculate the amount of thickening of the diaphragm and use that to determine if diaphragmatic weakness might be the cause of failed spontaneous breathing trials. So this is normal. This might be you or me. In a patient who has VID, ventilator-induced diaphragm dysfunction, as we talked about a few slides ago, with a strong effort, it may just stay like this. And there may actually be thinning of the diaphragm during quiet breathing. So it's something I think worth paying attention to, because increasingly this is a technique that is being used clinically. I know of at least one hospital where they're training respiratory therapists to do diaphragm ultrasound to make these kinds of assessments. Tom Pirano was telling me, actually when we saw him a couple of weeks ago, that they're training the therapist at St. Michael's Hospital in Toronto to do this.
So we've done a little bit of it in the obese patients during protocols. a totally different scenario because their diaphragms are unbelievably thick.
Yeah. Is it technically more difficult in the obese to do? I would think that it would be.
Yeah, to do any type of ultrasound, it's much harder to get a good fit. We have trouble getting, cardiac ultrasounds with them.
But there is a lot. I can tell you.
I don't think anybody's doing this. I don't think anybody's doing it, as you're making reference to, in looking at patients who are weaning. Maybe in select patients where there's problems, it's been done. But I don't think you guys would know better than me. I don't think this is...
I know a few years ago I brought this up on several occasions and got no traction. It didn't seem like there was anybody who thought of an ultrasound as anything other than a way to insert a central line. But there's lots more information that you can get from ultrasounders. A whole other subject is using ultrasound of the lungs during peak titration and so forth. But this is something I think we are going to hear more about. There are actually clinical trials that are going on to determine whether diaphragm ultrasound might be helpful to determine the reasons why patients fail liberation from the ventilator, or in patients who maybe we need to work on that before we try to get them off the ventilator. Okay, so now let's move our discussion away from respiratory muscles and let's talk about compliance. So the next series of slides has to do with pressure-volume relationships, which is compliance, because compliance is the pressure-volume relationship. So let's imagine that we take Eric's lungs, or Lloyd's lungs, you can flip for it, and we put your lungs inside of a tight jar, and we reduce the pressure outside the jar, causing the volume of the lungs to increase. If we do that in step changes, we will get this kind of a curve during inspiration, this kind of a curve during exhalation. So in other words, as we make the pressure around the lungs more negative, which is what we do with our diaphragm and chest wall muscles, the volume increases. And it's not a linear increase, it is a sigmoidal increase. And we'll talk in a minute about why it is sigmoidal. The other thing I should also point out here is here we're talking about normal physiology. So we're not talking about the pressure volume curve that we might see in a patient with ARDS, where the physiology is different. And we can talk about that maybe for the next lecture. So here we're talking about normal lungs. So this is not recruitment and so forth as it might be in a patient with ARDS. How the lung deflates is different than how it inflates. That is called hysteresis. And the slope of the pressure volume curve is compliance. So it's volume change per pressure change. So we have volume on the y-axis, pressure on the x-axis. So change in y over change in x, change in volume over change in pressure is compliance. So the slope of the curve is compliance. And a normal lung compliance, the lungs by themselves, so we take the lungs out of the thorax, so just the lungs without the thorax, normal compliance at functional residual capacity is 200 milliliters per centimeter of water. We'll talk about how that changes when we then put the lungs into the thorax and we measure lung and chest wall together. And the shape of that curve, so here we're just looking at the inspiratory curve. So the shape of this curve is determined by disease. So here is normal, beginning at functional residual capacity. Here is emphysema. So when patients with emphysema, their compliance is increased or decreased? Increased. It's increased due to alveolar destruction. So there is a higher compliance. There's less elastic recoil pressure. And that's why they have a barrel chest. So there's less elastic recoil pressure pulling in on the chest, so the chest expands outward. In a patient with pulmonary fibrosis, where there is scarring in the lungs, the curve is shifted downward, so there is a lower compliance. And here we're talking about compliance of the lungs. So then, why does the pressure volume curve appear the way that it does? So what are the physiologic causes of the shape of the pressure volume curve in normal individuals? So this is not ARDS, where de-recruitment and so forth come into effect. We don't, as normal people, we don't de-recruit our lungs when we exhale, and even if we exhale down to residual volume. So the physiologic causes of the pressure volume curve are due to small part by the elasticity of the tissue in the lungs, but by large part by surface tension. So surface tension is the biggest determinant of the shape of the pressure volume curve, or put another way, the surface tension is the biggest determinant of lung compliance, since the pressure volume curve is compliance. And in fact, if we take an excised lung and we inflate it with saline rather than with air, it's easier to inflate. So it's easier to inflate a lung with liquid than it is with air, because surface tension occurs at an air-fluid interface. So if we get rid of the air-fluid interface, the surface tension goes away. So then why don't we breathe saline? Or when our patients get sick, why don't we inflate their lungs with saline? It'd be easier to inflate with saline than it would be with air.
We tried it, it doesn't work.
That wasn't saline, that was fluorocarbon.
They tried saline before we tried fluorocarbon.
So the number one issue is that this is just looking at the lung parenchyma and compliance. So you would have to get that saline through the airways of the lungs, and your respiratory muscles are not strong enough to suck liquid through the lungs. So that's part of the reason. So this is just the lung parenchyma part, the compliance part. You can't get the saline to move through airways very well. A lot of friction. So that is one thing. The other thing is, how well does oxygen dissolve in water? Not very well. We talked about that in another lecture a few months ago. That's why we have hemoglobin in our blood to transport oxygen, because oxygen doesn't dissolve very well in liquid. So we could not get enough oxygen into the lungs to support life breathing saline. With perfluorocarbon, we can, because that has a much higher solubility for oxygen. And in fact, so you may wonder then, well, how can fish do that? Well, it's because they have gills rather than lungs, and the gills are very efficient, number one, and there's a counter-current mechanism and so forth. Also, little fish, even a big fish, can survive on very low oxygen concentrations. So the oxygen in the river that the fish is breathing is only about 5 parts per million. So they can survive with a very small amount of oxygen. And actually also in a very small range of oxygen. Whole other lecture. Maybe not a whole other lecture, because I don't know that much about it. a whole other subject. So then this illustrates the effect of surfactant. So surfactant, as I think I said, occurs at an air-fluid interface. So here we have a water bubble, and here we're looking at a blow-up of the air-fluid interface. So these are molecules of water in the droplet, and then up here we have the air. Or think about this as the lining of the alveolus, and then up here is the air within the alveolus. The molecules that are on the surface are being sucked inward by not by surrounding molecules, but by molecules below them. But the same forces do not exist up here in the air, at the air-fluid interface. So if molecules are being sucked into the fluid, the effect of that is to make the diaphragm, or to make the diameter of the air fluid interface as small as possible. So the effect of the surface tension will be a collapsing effect, in this case in the droplet, or in this case in the alveolus. And in fact, the law of Laplace says that the pressure inside of an alveolus is proportional to the surface tension divided by the radius. So in other words, in the alveolus with the smaller radius, there would be more pressure than the alveolus with the largest radius. So if surface tension itself was present without anything to counteract surface tension, so if we had surface tension without surfactant, what would happen in the lungs? All of the alveoli would collapse into one big alveolus. And that wouldn't be so good. I think we would all agree. So this then is counteracted by the effect of surfactant. So surfactant is a phospholipid. So here we have this hydrophobic head, which stays out of the water, hydrophilic tails, which go into the water, so that the surfactant lines up along the air fluid interface, and in that way counteracts the effects of surface tension. So the surface tension is less in the presence of surfactant. So then, in the presence of surfactant, it makes it easier to inflate the lungs because the surface tension forces go away to a large extent. And also, what happens in this smaller alveolus? So imagine that we have the same number of surfactant molecules in every alveolus. In this small alveolus, as the alveolus gets smaller, what happens to the concentration of surfactant in this alveolus? It becomes greater. I drew this bigger solid red line. So in the presence of surfactant, as the radius decreases, the surface tension also decreases. So the pressure does not increase. So with surfactant, then surface tension makes it easier to inflate the lungs, and it prevents the little alveoli from dumping into the big alveoli. So physiologic effects of surfactant then are to decrease the overall compliance of to increase the overall compliance of the lungs. So surfactant makes it easier to breathe in because it counteracts that air fluid interface. It maintains alveolar stability, so we don't have the little alveoli dumping into the big alveoli. And it also helps to keep the lungs dry because surface tension tends to draw water into the alveolus. So using surfactant to counteract surface tension helps to keep the alveolus from being flooded. Now, something else that is important to appreciate is that there is a pleural pressure gradient in all of us. The pleural pressure is more negative at the top of the lungs and less negative at the bottom of the lungs. So sitting upward, pleural pressure is more negative up here than it is down here. And that's a gravity effect. If you lie supine, then the pleural pressure is more negative up here, less negative down here. Now that has clinical implications. So if you think about this, the alveolus at the top of the lungs is on a less compliant part of the volume-pressure relationship. The alveolus at the bottom of the lungs is on a more compliant part of the volume-pressure relationship. So that then, alveoli at the top of the lungs are larger. They're exposed to more negative pleural pressure, so they're larger than alveoli at the bottom of the lungs, but most of the ventilation goes to the bottom of the lungs. And the reason that most of the ventilation goes to the bottom of the lungs is because the bottom of the lungs are on a more compliant part of the volume-pressure relationship than the alveoli at the top of the lungs. So we breathe in. So as I breathe in, I have more air going down here than I have going up here. Why is that a good thing?
Because that's where gas exchange occurs?
That's where the blood's going too. So due to of gravity, more blood flow at the bottom of the lungs than the top of the lungs. So that then results in a better ventilation-perfusion relationship. So then what happens if we really reduce lung volume? So we blow out as much breath as we can. Now what can happen is there's still a pleural pressure gradient, but now not only is the pleural pressure less negative at the bottom of the lungs, it actually becomes positive. And then what happens at that point? So if the pleural pressure becomes positive at the bottom of the lungs, so what's the pressure inside the alveolus? 0. The pressure outside the alveolus is, in this example, 3.5. There's going to be collapse in the dependent parts of the lungs. So here is illustrated the reason why atelectasis tends to occur first in the more dependent parts of the lungs because of the pleural pressure gradient. And the benefits of prone position have been explained in part as a result of the pleural pressure gradient. So in the supine position, in a patient with ARDS, the more ventral part of the lungs, so in the supine position up here, the more ventral part of the lungs has a more negative intrapleural pressure, whereas the dorsal part of the lung down here may have a more positive intrapleural pressure due to the weight of the lungs with ARDS. So there's a lot of dependent collapse. And we try to counterbalance this with peak, for example. If we then take this patient and we put them into a prone position, now there is a lower pleural pressure gradient. So notice here the pleural pressure gradient has gone from -10 to +15. Here the pleural pressure gradient has gone from -10 to -2. So in the prone position, there is a decrease in the pleural pressure gradient. Notice now that the dependent ventral pleural pressure is negative, so that the effect of prone position is to decrease the amount of dependent atelectasis. One of the mechanisms, perhaps the most important mechanism as to why prone positioning may be effective. So it improves dependent alveolar recruitment. So a little bit about chest wall effects and then we will stop. So normally the lungs are trying to collapse inward. So due to surface tension and elasticity, the lungs are trying to collapse inward. Normally, the chest wall is trying to expand outward. So what would happen is if you came up here and you took off my head and you pulled out my lungs and you put my lungs and my thorax on the table, you would see that my lungs would go like this, my chest wall would go like this, and I wouldn't be very happy about it. But it would illustrate an interesting point of respiratory physiology. With a pneumothorax, what happens is that the pleural pressure becomes 0 or perhaps even positive with tension pneumothorax. And then that allows the chest wall to expand outward and the lung to collapse further inward. So there's lung collapse with pneumothorax. Some of the old books used to say that if you suspected a tension pneumothorax, you could try to judge how large is the chest wall and how much distance there is between ribs and so forth. That all seemed to be not very clinically applicable, although it may be true. So the last slide that I'll show today, because this is kind of a bit of a complicated slide, but we'll try to walk through it. So then if we put it all together, so here we're looking at volume and pressure. Here is the chest wall, normally. So you or me, not morbid obesity, not ARDS, normal people. So here is the chest wall. And notice that the chest wall, unless we're at very high lung volumes, the chest wall by itself generates a negative pressure. That's because the chest wall without the lungs tries to expand outward. which makes the pressure more negative inside the thorax. Here is the lung by itself. Notice that at all volumes, the lung by itself generates a positive pressure because the lung's trying to expand inward. But we don't have the lung by itself or the chest wall by itself. We have the lungs in the thorax, the lung in the chest wall. So respiratory system compliance, which is what we usually assess clinically, is the combination of the two. And where the airway pressure is 0, this is functional residual capacity, FRC, where the negative outward pressure of the chest wall completely balances the positive inward pressure of the lungs. So then when we passively exhale, why do we exhale at FRC and we stop if we're passively exhaling? Because at FRC is where the outward pressure of the chest wall is completely balanced by the inward pressure of the lungs. So the isolated lung expands outward, except at very high lung volumes. The isolated lung collapses inward. At FRC, the alveolar pressure is 0, and the pleural pressure is negative. So if at FRC, the alveolar pressure is 0, there's no such thing as physiologic PEEP. And I can recall doing 20 years of lectures to the medical residents when I always tell them, please don't say that we use PEEP because it's physiologic. Physiologic PEEP is 0. Lots and lots and lots of good reasons to use PEEP. I'm all for using PEEP, but not because it's physiologic. So in you and me and normal people, the alveolar pressure is 0 at end exhalation. Now the compliance, at FRC, the compliance of the lungs. So if we look at this curve, the slope of this curve right here is 0.2 liters or 200 milliliters per centimeter of water. If we look at the chest wall, right here, the slope is also 200 milliliters per centimeter of water, 0.2 liters per centimeter of water. But when we put them both together, the slope is less. So notice this slope is less than this slope and this slope. So the compliance of the respiratory system normally is 100 milliliters per centimeter of water, 0.1 liter per centimeter of water. So then why is the compliance of the respiratory system less than the compliance of the lung or the chest wall by itself? It's because when we put the lung and the chest wall curves together, the resultant respiratory system compliance curve has a lower slope. And we can also illustrate that by using the inverse of compliance, which is elastosis, and come up with the same result. So I said this would be my last slide, but maybe I'll do one more, because this is a clinical question that comes up sometimes. So why is the compliance decreased with a loss of lung volume, like atelectasis or consolidation, when the elasticity and surface tension are unchanged? I actually had somebody who used to work here who emailed me this question about 6 months ago. So why is it that the compliance goes down when you get pneumonia? Because the resulting lung should have a normal lung, which is true. And here is the reason why. So if you put in a volume and the volume goes to 2 alveoli, half of the volume goes to each alveolus. So if we put that on the pressure volume curve, if the starting point is here, for an individual alveolus, the volume goes from here to here and results in this compliance. But now, let's imagine that this alveolus collapses or it fills up with pneumonia, pus, consolidation. If we put in the same tidal volume, now all the volume only goes to this alveolus. So this alveolus doesn't take half of the volume, it takes all of the volume. So that then, if you look at the volume change, we go from here to here in this alveolus. And when we go from this point to this point in the alveolus, what happens to the shape, what happens to the slope of the curve, which is compliance? Decreases. So then that produces the illusion clinically that there's a decrease in compliance. But if you reduce the volume in relationship to the reduction in lung available volume in the lungs, you would see that the compliance doesn't change. So here, if this is a 500 milliliter tidal volume, I submit to you that if you reduce the tidal volume to 250 milliliters, because the breath is only going into the half of the lung, you would get the same compliance. Put another way, push in the big volume, you get overdistension. So that's the reason why it appears as though, so you have a patient on volume control ventilation, put in the same tidal volume, and they develop cardiogenic pulmonary edema or atelectasis or pneumonia, the impression is that the compliance gets worse. The compliance has gotten worse because we did not reduce the tidal volume from the ventilator. Okay, with that I will stop, and the next time we will pick up by talking about airways resistance, and then we'll try to talk about this clinically. So how can we measure some of these things that can be related?